Asymptomatic Bacteriuria Management at Armadale Health Service. Armadale Health Service is a 250-bed general hospital within East Metropolitan Health Service in WA. In 2018, an audit was commenced to determine how effectively the service was managing cases of asymptomatic bacteriuria, or ASB. ASB is defined as an isolation of a specified quantitative count of bacteria in an appropriately collected urine specimen from an individual without signs or symptoms of a urinary tract infection. A Choosing Wisely recommendation from the Australian and New Zealand Society for Geriatric Medicine is do not use antimicrobials to treat bacteriuria in older adults where specific urinary tract symptoms are not present. ASB is more common in elderly patients, and inappropriate urine testing should be avoided to reduce unnecessary treatment of ASB. This is because positive urine cultures, irrespective of whether the patient is symptomatic, can act as a driving force to treat. Inappropriate treatment of ASB can have potential negative consequences for the patient, including additional cost and burden, side effects of antibiotic use, such as Clostridium difficile infection, development and contribution to antibiotic resistance, including extended spectrum beta-lactamase producing organisms and carbapenem-resistant Enterobacteriaceae. Finally, colonization without symptoms can be potentially beneficial, as some uroprotective strains of Escherichia coli may protect from more invasive organisms. The aim of the audit was to determine, over a 3-month period at Armadale Health Service, Rehabilitation and Aged Care Ward, 1. The frequency and appropriateness of urine microbiology testing. 2. The quality of urine samples collected. 3. The reported microorganisms and their sensitivity patterns. 4. The documented indication of catheter insertion in patients with a catheter specimen urine received by the pathology laboratory. The audit sample included all patients with a urine sample sent for microbiology testing whilst admitted to the Rehabilitation and Aged Care Ward over the 3-month period from June to August 2018. Information was collected retrospectively from a combination of patient medical records and electronic pathway results. In a review of the patient medical records, symptoms of a UTI included fever greater than 38 degrees Celsius, nausea or vomiting, urinary urgency, frequency or dysuria, costrovertebral, suprapubic or flank pain or tenderness, acute hematuria, altered mental state, rigors, new or worsening incontinence, sepsis or shock, if there was no other obvious cause. Additionally, a urine sample was considered of poor quality if it contained mixed growth and/or epithelial cells greater than 10 × 10 to the power of 6 per litre, as indicated in the PathWest reports. Data was analysed in Microsoft Excel and de-identified prior to reporting to maintain patient confidentiality. The project was registered with the WA Health System Project Governance Database prior to commencing. There were 63 patients and 99 urine tests indicated in the audit. Of the 63 patients, 59% were female, the median age was 82, and 12 had a urinary catheter. Out of the 99 tests, 45 were taken from patients without documented symptoms of a UTI. The most commonly documented symptom was frequency or urgency, being recorded for 21 out of 86 or 24 of urine tests. 60% of the 99 samples were low quality or contaminated, with contamination being much more common in females with a contamination rate of 75 compared to 36% in males. 47 organisms were isolated, with the most common of these being Escherichia coli, which was isolated in 19 or 40% of samples. In non-catheterized patients, 15 out of 87 or 17% were colonized in the absence of symptoms, consistent with a diagnosis of ASB, and 9 of these 87 patients, or 10%, were treated with antibiotics. In catheterized patients, 5 out of 12 were colonized in the absence of symptoms, consistent with ASB, and 3 of these patients, or 25%, were treated with antibiotics. There are 4 recommendations from this audit. Firstly, to feed back audit results to the relevant staff on the rehabilitation and aged care ward in conjunction with a brief education session. The second recommendation is to develop an education package for nursing staff on appropriate MSU testing and MSU technique to avoid contamination. Next, to promote appropriate use of urine testing. And finally, to develop a new prospective audit tool to enable real-time data collection and monitoring of urine sample collection to allow ongoing feedback. This prospective audit could also act as an aide memoire to ensure only patients with symptoms have urine sample tests taken. In summary, this audit highlights that urine samples continue to be collected from patients without symptoms of UTI, with a proportion being administered possibly inappropriate antibiotics. There is potential to improve the quality of the urine samples, particularly from female patients. Further education and interventions are required to improve the management of suspected urinary tract infections on the rehab and aged care ward at Armadale Health Service, and more broadly of the hospitalised older patients.